Welcome to AETCM, the emergency medicine channel. Today let us discuss about metabolic acidosis, one of the important acid-base balance in emergency room. So previous class we have learned that our body pH is maintained in between 7.35 to 7.45 by our lungs and kidneys. Lung with carbon dioxide and carbonic acid increases or decreases pH by increasing carbonic acid or decreasing carbonic acid, whereas kidney will try to remove hydrogen ion and increase or decrease bicarbonate levels and try to maintain the buffering system. When hydrogen ion increases, pH decreases, the patient develops acidosis. When hydrogen ion increases on one side, pH increases and it can go to alkalotic side. Now we will discuss about metabolic acidosis. There are a lot of causes for metabolic acidosis. We will see it afterwards. So here primary mechanism is fall of bicarbonate level. So HCO3 minus levels are reduced and that produces metabolic acidosis. The causes may be different, but the basic problem in acid-base balance is bicarbonate levels are reduced. So you can see here bicarbonate reduces, so patient develops acidosis. Then pH also reduces, that indicates acidosis in ABG. And initially PaCO2 levels are normal, but after some time body will try to compensate by adjusting the carbon dioxide in the lungs. So till then bicarbonate levels are reduced, that reduces the pH. So we can calculate the compensation by this method. So we have already learned that when the bicarbonate is reduced, that produces acidosis. So to compensate that, carbon dioxide also reduces, that reduces the carbonic acid, and it also reduces the improves the compensatory mechanism, and pH will come to near normal. It is in the normal limits. pH will never cross to the opposite side of the midline. So we can calculate PaCO2 by 1.5 into bicarbonate plus 8. That will give you the expected carbon dioxide level. Suppose the patient is having an additional problem like there is hypercarbia due to COPD, the carbon dioxide may go very high than this, or if the patient is having a hyperventilation syndrome and carbon dioxide washout, we will not be seeing this expected carbon dioxide correction. So in a person who is having isolated metabolic acidosis, initially bicarbonate is reduced, pH is reduced, but after some times lungs will try to compensate, carbon dioxide washout can occur, and you can get pH will come back to near normal or within the acidotic side, like it will be 7.35 to 7.3. It will never cross to the opposite side of 3. That means it will never go to the alkalotic side. If the pH going to alkalotic side, we have to always think that an additional metabolic alkalosis or respiratory alkalosis is there in the picture. So we can calculate the compensation. Other compensations are given here, but I will not be discussing that now. When we discuss other cases, we will be discussing that. So metabolic acidosis, pH is reduced. Primary problem is bicarbonate is reduced. To compensate that, lungs will try to remove carbon dioxide by hyperventilation. So expected carbon dioxide level also we can calculate by this. Now you can see here metabolic acidosis, pH is reduced, defect is bicarbonate is reduced. For compensation, HCO3 minus is also reduced. Every 1 millimeter of PaCO2 reduction, or there will be reduction of 0.5 milliequivalents of bicarbonate. So the metabolic acidosis whenever there is metabolic acidosis, you can see the bicarbonate levels are reduced. For every 1 milliequivalence of bicarbonate reduction, there will be 1.25 millimeter of mercury PaCO2 reduction can be there, and pH can be reduced by 0.012. So you can use this formula also to make out what is the expected carbon dioxide reduction. Or if you are finding anything extra, you have to think that there is an additional acid base disorder. So you can get metabolic acidosis in diarrhea, proximal artery, diabetic ketoacidosis, alcoholic ketoacidosis, lactic acidosis, salicylate poisoning, renal failure. So many conditions you can get metabolic acidosis. So metabolic acidosis is the accumulation of acid, that is hydrogen ion, when compared with base due to increased acid production or acid ingestion, decreased acid excretion, or third one is gastrointestinal or renal bicarbonate loss. So increased production of metabolic acids like ketoacidosis, diabetic ketoacidosis, ketone bodies are produced, alcoholic ketoacidosis, lactic acidosis, or any other toxic alcohol induced metabolic acidosis, methanol, ethanol, all these things can also produce metabolic acidosis. Loss of bicarbonate through GIT in severe diarrhea, through kidney, proximal, renal, tubular acidosis. Failure of hydrogen ion excretion by kidneys, that will accumulate hydrogen ion and produces acidosis, renal failure and distal renal tubular acidosis. Ingestion of potential acid, salicylate poisoning and ammonium chloride poisoning. So these are the common causes for acidosis. In that, most important cause in clinical practice is always diarrhea and diabetic ketoacidosis. In sepsis, lactic acidosis is very common, and those who are taking alcohol, they can have acidosis either because of alcohol itself, or it can be due to methanol, ethanol, ethylene glycol, like that toxic alcohols. Now once you understand the patient is having acidosis, metabolic acidosis, once you take the ABG, you can immediately see that pH is reduced, bicarbonate is reduced, either compensation has occurred or not occurred. Whatever it is, you have to see the anion gap. So anion gap is the difference, it's a difference between sum of routinely measured cations minus sum of routinely measured anions. We will see how to calculate this. So in an ABG itself, you can get sodium, potassium, chloride, calcium, all electrolytes and minerals can be available in most of the newer ABG machines. So you can calculate it, sodium plus potassium, that is the measured cations, minus chloride plus bicarbonate, they are the measured anions. So you can see the difference. If the difference is very high, then that is unmeasured ions. So anion gap should be calculated from these values, which is available in the ABG value itself in most of the newer ABG machines. So we will see what are the common condition which produces HAGMA or high anion gap metabolic acidosis. Increased endogenous acid production, diabetic ketoacidosis, accumulation of ketones, starvation ketoacidosis, accumulation of ketones, lactic acidosis, tissue hypoxemia or liver disease, renal failure, accumulation of organic acids, increased exogenous acid, aspirin poisoning, accumulation of salicylate, methanol poisoning, accumulation of formate, ethylene glycol poisoning, accumulation of glycolate, oxalate. So you can calculate the anion gap by sodium plus potassium minus chloride plus bicarbonate. So you can see the picture here. Normal anion gap metabolic acidosis, you can see the anion gap in these two pictures, sodium plus potassium minus chloride and bicarbonate. That difference you can see the middle part. So that's a normal gap, normal anion gap metabolic acidosis. But whereas in third area, the anion gap is increased. That means there are some unmeasured anions or other ions are there in the blood that we are not routinely measuring, but that can produce all these complications. That will tell you the patient is having some of the problem like DKA or lactate or uremia or methanol, ethylene glycol poisoning or aspirin poisoning. So that can be easily picked up by high anion gap metabolic acidosis. Afterwards, depending on the clinical scenario, suppose somebody is having metabolic acidosis, anion gap is very high. His lactate is very high means it is lactic acidosis. Suppose blood sugars are very high, then you have to check for any ketone bodies in the blood. If creatinine is very high, then you can see what is the urea. Most of the newer ABG machines also give creatinine values. Then methanol and ethylene glycol poisoning, we have to suspect when the patient is having alcohol smell, and if they are complaining about visual loss or any types of arrhythmia, we have to think about toxic alcohols. Now, high anion gap metabolic acidosis, you can remember with mnemonic, that is a cat mud pile, aspirin, carbon monoxide, cyanide, caffeine poisoning, paracetamol poisoning, theophylline poisoning, methanol, metformin. Metformin as such will not produce metabolic acidosis, but very high dose of metformin, like metformin poisoning, high dose of metformin intake can sometimes produce this problem. Uremia, that is renal failure, diabetic ketoacidosis or alcohol ketoacidosis, propylene glycol, that is a toxic alcohol, isoniazid, ibuprofen, iron toxicity, lactic acidosis, ethylene glycol, that is also toxicity. Or you can just remember mud piles, methanol, uremia, diabetic ketoacidosis, fenformin, that is metformin's previous generation drug, that actually produces metabolic acidosis even in a smaller dose. Nowadays fenformin is not available, we have only metformin, but higher dose of metformin only will produce acidosis. Otherwise routine doses will not produce metabolic acidosis. Iron, INH toxicity, lactic acidosis, ethylene glycol poisoning, salicylates, starvation, ketoacidosis. So any ketoacidosis can produce metabolic acidosis. Normal anion gap acidosis, all other causes which can produce acidosis other than we studied in the previous slide can produce normal anion gap metabolic acidosis. So with a tendency to hyperkalemia, then you can see it's a recovering phase of DKA, early uremic acidosis or late uremic acidosis recovering from renal failure, early obstructive uropathy, renal tubular acidosis type 4, hypoaldosteronism, that is Addison's disease, infusion of various materials, acid materials, potassium sparing diuretics, renal tubular acidosis type 1 which can produce hypokalemia. Type 2 also will produce hypokalemia. Only type 4 will produce hyperkalemia. So anybody is having normal anion gap metabolic acidosis with hypo or hyperkalemia, you have to think about renal tubular acidosis. Acetosolamide, acute diarrhea with loss of bicarbonate and potassium, uretrosigmoidoscopy, obstruction to the artificial ileal bladder, that's a bladder reconstruction surgery, dilution acidosis that occurs after normal saline infusion, hyperchloremic metabolic acidosis, but clinically these things are not very important. The most important thing in this group you can see here, that is renal tubular acidosis and diarrhea. So these are the two important causes which produces metabolic acidosis, normal anion gap metabolic acidosis. So you can remember like this: saline infusion, hyperchloremic acidosis. This is very common in clinical practice because like conditions like shock or diabetic ketoacidosis, we use large amount of normal saline. This can produce some amount of acidosis, but remember this acidosis, normal saline induced hyperchloremic metabolic acidosis are clinically benign. They will not produce any problem clinically, but the ABG may show acidosis. Exogenous acids, ammonium chloride, hydrochloric acid, carbonic anhydrase inhibitors, acetazolamide, uretic diversion, that's a type of surgery, urinary mucosal produce bicarbonate loss, diarrhea due to loss of bicarbonate, hypoaldosteronism, adrenal insufficiency, Addison's disease, intestinal fistula, renal tubular acidosis. So you can see this list. One of the most common cause for normal anion gap metabolic acidosis will be severe diarrhea. That will be the most common cause. Then renal tubular acidosis is one of the important cause in patients admitted in ICU and wards. And if the patient is having has received large amount of normal saline, then it is saline infusion induced hyperchloremic acidosis. But that condition is always benign. We no need to worry about that condition. Here one important condition is diarrhea and renal tubular acidosis. One important condition we miss in most of the cases is renal tubular acidosis. We never think about routinely we never think about renal tubular acidosis. It can be produced by various diseases and various drugs. So we have to be very careful. This can produce problem in patients who are admitted in ICU. Now we know that when the body is having acidosis, body will try to remove carbon dioxide by excessive breathing. That is called as Kussmaul's breathing. It is deep, regular, rapid sighing respiration. You can see the causes for Kussmaul's breathing. Remember Kussmaul: ketosis, uremia, starvation ketosis, methanol, ethylene glycol, aspirin poisoning, lactic acidosis. So whatever we have seen in the previous slide, it is same, but Kussmaul's breathing can be produced by acidosis, various type of acidosis. That major causes we can remember with a mnemonic Kussmaul. Patient can also have hypotension, arrhythmias, headache, confusion, coma. Now this is Kussmaul's breathing. Compare with the normal breathing. Normal breathing, you can see the first tracing. Second tracing shows how deep it is, how fast it is. You have to compare with the normal. This one, you can see the relationship of kidney and lung in maintaining our acid-base balance. When there is acidosis, especially metabolic acidosis, lungs will try to increase or decrease carbon dioxide to maintain the pH in between 7.35 to 7.45. So here alkali is reduced, patient has gone to acidotic side, that is metabolic acidotic side. Lungs will try to remove carbon dioxide, that carbonic acid is removed. So what happens is the body will try to maintain the equilibrium, pH equilibrium, so that acidosis slowly getting corrected by lung. Now when we treat a patient who is having metabolic acidosis, whatever may be the cause, we have to investigate. So we are getting a patient who is having rapid breathing, we are suspecting acidosis, we have to take an ABG. That is the first thing we will do. ABG findings we have seen in the previous slides. pH is reduced, bicarbonate is reduced, then initially carbon dioxide there will not be any change, but afterwards carbon dioxide washout will occur and it produces compensation. This is called as compensation. Then we have to see blood sugars, ketone bodies to rule out DKA, serum potassium, creatinine, urea, sodium chloride. All these things you can do to rule out urinary failure, kidney failure. Lactate levels more than 2 are significant. Serum levels of salicylates if you are suspecting salicylate poisoning. Urinary pH, urine ketones also very important to know whether renal tubular acidosis, these things are important. Arterial blood gas analysis we have seen in the previous slides. Anion gap calculation is very important. Toxic alcohol levels, if you are only suspecting alcohol induced or toxic alcohol induced problem, we have to send. Now there is another value can be calculated in anion gap metabolism, that is delta gap. Anion gap minus 10 by 24 minus bicarbonate level we can get. If the value is less than 1, it indicates a mixed metabolic acidosis, like a non-anion gap acidosis and a high anion gap acidosis. So that can be calculated. Suppose the patient is having severe diarrhea, then he develops lactic acidosis because of fluid involvement like a reduction in the body fluids. So you can get this type of problems. But clinical examination history all are very, very important in this type of conditions. So if you see only lactic acidosis, if you have not taken the diarrhea part, you may miss the diarrhea and you may miss the diagnosis. A value more than 1.6 indicates mixed metabolic acidosis and metabolic alkalosis. So this also should be calculated when we have doubt. Now base excess and base deficit, that is another thing we can get in the ABG itself. Most of the ABGs will give that plus or minus 2 milligrams is normal. Base excess or deficit of plus or minus 2 milligrams is a normal in normal ABGs. A positive number is called base excess and that indicates metabolic alkalosis. A negative number is called as base deficit, that is indicating metabolic acidosis. Severe metabolic acidosis is associated with base deficit of minus 10 milligrams per liter. So that also will be given in the ABG value. So positive number plus 3 plus 4 indicates metabolic alkalosis, or minus 4 minus 3 minus 5 like that indicates metabolic acidosis. Now another important thing is osmotic gap. So this will be done to know any other abnormal alcohols are there in the blood or not. But normally this type of calculations are not required in emergency room, because nowadays we get all types of toxicology analysis from the toxicology lab itself. Point of care instruments are there, we get it like that. But however, for a beginner, we have to learn, as a beginner, we have to learn all these things. This is called as osmolar gap. You can detect any abnormal alcohols like methanol, ethylene glycol and all through this calculation. You can calculate, you can see the difference between the actual osmolality that is measured by the laboratory and the calculated osmolality. That difference is osmolar gap. So you can calculate the osmolality, that formula is given. Then you will get the osmolality from the machine. So the difference between that is osmolar gap, that indicates some toxic alcohol induced problem. So elevated osmolar gap is normally seen in ethanol, methanol, ethylene glycol, sorbitol, mannitol, hypertriglyceridemia, hypergammaglobulinemia like multiple myeloma. So that can be calculated and you can get a possible etiology for the altered behavior or acidosis. Now this is the chart which will tell you how to go ahead with acidosis. If the pH is less than 7.35 or 7.36, you can call it as acidosis. Now we will be discussing only metabolic acidosis here. pH is reduced, bicarbonate is reduced, body will try to remove carbon dioxide through lungs, so PaCO2 is reduced. This is called as compensation. Once you understand there is acidosis, you have to see whether this is high anion gap acidosis or normal anion gap acidosis. Normal anion gap acidosis, we have seen that it's one of the most common causes diarrhea, then renal tubular acidosis. All other major acidosis come on high anion gap acidosis like DKA, lactic acidosis, renal failure, methanol poisoning, ethylene glycol poisoning. All these things come on high anion gap acidosis. Other things we will discuss afterwards. When we discuss that type of cases, we will discuss. Now, the most important treatment in any acidosis, find out the cause, treat it. That is the most important cause. But when the patient is having acidosis, it is always better to give fluid, and once you are giving fluid, most of the time patient will have severe dehydration. Whatever acidosis you take, most of the time patient will have severe dehydration. So IV fluids are the mainstay treatment in most of the acidosis. Then soda bicarb, that is sodium bicarbonate therapy, can be given in patients who is having acidosis, but it is only having a covering up effect, because it is not going to alter the problem in the patient. Whatever we give, like soda bicarb, whatever dose you give, it will not change the clinical problem of the patient. Clinical problem, we have to treat it properly with proper drugs. This will only improve the acid-base balance in the patient, but it is not the definitive treatment. Some conditions like patient is having hypotension, shock, or we are not able to do anything. In that type of condition, Soda bicarb may transiently transiently it may be effective, but it is not a permanent cure. So in all patients who is having acidosis, giving soda bicarbonate is not recommended. For something like if the patient is coming with severe diarrhea and he has developed a normal anion gap metabolic acidosis, instead of correcting the fluid problem, if you are giving soda bicarb, it can correct the ABG status, but patient will never improve. Like that lactic acidosis, if the patient is having dehydration, lactic acidosis, if you are giving soda bicarb, it will correct the pH, it will correct the bicarbonate level, but patient will not improve. Only conditions like renal failure and all, if you are not able to do anything immediately, dialysis on the way, then you can give soda bicarb and try to bridge between the definitive therapy to the acute problem. Many patients may require hemodialysis in various type of acidosis, like renal failure itself, dialysis indicated, toxic alcohol induced problem, renal dialysis can be indicated, salicylate poisoning you can give dialysis. So many conditions we have to advise dialysis, and many patients who is having renal failure, that type of patients can have potassium disorders. Renal tubular acidosis can have both hyperkalemia and hypokalemia. So various electrolyte imbalance also can be there. Now we will just see one of the important problem, that is decay. Decay, you can remember the treatment like this: airway should be taken care, breathing, circulation, diabetic history and blood sugar values to be taken. Blood sugar values should be taken every 1 hour till the patient improves. Electrolytes like potassium, pH should be done. Fluid management is very, very important. We have to give normal saline, that is a initial choice of fluid. Once the patient is stabilized and the blood sugar is at 250 or less than 250, you can switch to DNS. Then glucose monitoring is very, very important, because rapid drop of blood sugar is dangerous. So we have to have a graded reduction of glucose, 75 milligram per hour, that is an ideal reduction. Hypokalemia should be managed, because many patients who is having hypokalemia, if you start him on insulin infusion, there will be shift of potassium and further hypokalemia can produce severe arrhythmias. So we have to be very careful. Insulin infusion should be started at rate of 0.15 units per kg. As an infusion, it should be given in patient who is having decay. But remember, potassium correction should be done before that. JVP or CVP. JVP should be seen in a primary to secondary care settings to see what is the fluid status. CVP, central venous pressuring, can be monitored. IVC collapsible can be monitored in a tertiary care center. Ketone bodies should be done in blood, not to be done in urine. Urine, it can be positive, but even after correction of decay, you can get ketone bodies in urine for some more time, and sometimes you may not see ketone bodies in urine even with presence of decay. So ketone bodies in urine is not a very good investigation, but if blood ketone body levels are not available, we can depend on that. Lower dose of insulin infusion should be continued even after patient improves. Then once the patient is taking oral feeds, then you can overlap subcutaneous insulin with insulin infusion. Monitor blood pressure, all these things, like any other patient, we have to continuously monitor these patients. So this is the chart which will help you to treat decay. I am not going to the details of decay now. So main treatment is give fluids. Normal saline is the treatment of choice. Like you take any acidosis, fluid has to be given in acidosis. Correction of acidosis can be done with even with fluid alone in most of the acidosis. So fluid should be given. Then potassium correction has to be done. Then only we have to correct the sugar level. So sugar should be corrected with insulin. You can start it as an infusion protocol, and once the patient is stabilized and if the patient is taking oral, you can continue the insulin infusion for another half an hour, but you have to give a loading subcutaneous dose before stopping the insulin infusion. And always check the pH values to see whether the decay is corrected or not. To see that, you can see the venous blood sampling. No need to prick every time to get an ABG in metabolic acidosis like this. If the patient is having a respiratory acidosis, it is always better to take an arterial blood. But in a patient who is having metabolic acidosis, serial monitoring of pH and bicarbonate, venous sample is as good as arterial sample. So that also can be done. So we have discussed about one of the important acid-base imbalance, that is metabolic acidosis. When we learn about metabolic acidosis, we know that there are various causes for metabolic acidosis. It's again divided into high anion gap metabolic acidosis and normal anion gap metabolic acidosis. One of the most important condition which produces normal anion gap metabolic acidosis is diarrhea. But a patient who is having diarrhea with severe dehydration can produce lactic acidosis because of the severe dehydration and reduced organ perfusion. So the same patient can have two types of acidosis due to same condition. And there are a lot of other conditions like renal tubular acidosis. That is one condition can produce acidosis with hyperkalemia or hypokalemia. So electrolyte imbalance is very important. Many patients who is having severe dehydration can have hypernatremia. Sodium levels are very high. So all these things we should learn, because repeatedly if you are seeing this type of cases, it will be very easy to understand acid-base balance. If you are learning only theoretical part, and if you try to learn all these calculations without seeing patients, it will be very difficult to understand the acid-base disorders, because it's every patient acid-base disorders are different. Some patient you can get a combination of metabolic acidosis with metabolic alkalosis. Some patients you can have two metabolic acidosis in same patients. Some patients you can have one metabolic acidosis alone. After treating, you may develop another metabolic acidosis, because like you can get in diabetic patients decay when you are treating with normal saline from high anion gap metabolic acidosis, they go to another type of acidosis, that is hyperchloremic acidosis because of IV fluids. So many combinations also you can get during your practice. Thank you.